Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Okay, semua ada dah?
Dah. 9.
Is everyone here? Everyone here, right? Can you start? Seorang je lelaki ke? Oh, is it more? Okay, ada few. So how many of you total?
9.
Okay, 9. So that's a good number. Frankly speaking, I think how many classes have you guys gone through so far since the beginning of your pediatric posting? Have you had any classes with other lecturer yesterday or the day before? I mean the case-based learning, what you call it, the PBL.
No, this is the first time in PID posting.
So previous posting, have you had similar session?
PBL, yes, we have.
Who ran the PBL? Is it which department? Medical. IM.
Medical, IM.
So how do they run is it different in all lecturers? I mean among the lecturers, are they use the same approach or different approach? Or how is it? How they run the class?
Depends on the doctor itself. Some want us to do the PE first, some I don't know. Depends on the
Yeah,
doctor.
I mean online kan? You did class online kan?
Yes,
So
online.
how they run the program? How they run the class?
Like one people will present the screen and then be the subscriber while others are discussing the case.
So you are the chair, you are the scriber.
Yes.
Oh, that's interesting. So you've got 2 sessions for one PBL. You've got 2 sessions for one case.
Just one session.
Then that is not called PBL.
During EMS, we used to have we did 2 sessions, but for the online class so far, for year 3, only 1 session.
So who decide your ILOs, your intended learning outcome? I mean from the case, who actually decide in your PBL session during your IM punya posting kan? Who actually decide what you want to learn and what you have to learn, your intended learning outcome from the case? Who actually decide that? Kan waktu you guys buat BMS kan, Basic Medical Sciences, you ada PBL session kan? I believe PBL, because the way I learn in the past, my undergraduate is a full PBL. We don't have classes. We've got full PBL. In my university, we've got full PBL. So how the PBL works is actually you open the case in the early of the week, you open the case and you decide among the groups what you want to learn from the case. And then at the end of the week, you close the case, you wrap up and discuss. With there'll be one tutor lah, non-medical tutor in the group. Kan? Macam tu kan PBL. That how PBL should works lah. Okay, you guys buat macam mana? Because actually waktu we had a department meeting, I think about 2 weeks ago. That's when they decided to do PBL. But none of us, except for myself, had PBL. Except for myself. So the way I had my PBL in the past during my undergrad is that's how it goes lah. That's how it went. Tapi the other lecturers, they never had any PBL, so their understanding of PBL is different. Because the outcome will be different, based on a lot of study done, looking at the pedagogy. I mean the method of teaching. PBL, the outcome, short-term and long-term outcome of PBL, case-based learning, flipped classroom, all this blended learning semua lain tau. And it depends on how you run the class. I know it's a bit complicated and it's a bit technical, but I don't intend to do PBL lah with you guys, because to do PBL you need to plan properly the case, and the case has to be what you call, how to say it, consecutive. It has to, it needs a follow up lah, follow up cases. It has to be related one to another. So I don't think PBL will work lah during macam online macam ni. Anyway, so how I'm going to run the case, the class, this is the way, this is my way lah. Because this is, you are the first class. Okay, you are my first class of the current semester that we start to do this kind of case-based learning. In the past, your previous colleague and also your seniors, what I did most of the time, because I know you never clerk any case, right? Any pediatric case, have you? No, never. What happened in the past, even I think Dr. Musa, how he did is actually he gave you guys a case write-up done by your seniors or by your colleagues, kan? I don't think that works, or I don't think that that will give you any benefit. So what I'm going to do today is I already give you 2 cases, kan? Okay, and I think, and I hope you guys read through the cases, understand the cases, at least the basic sciences behind it. So what we're going to do is we're going to do like similar to like PBL, but this is a case-based learning. So we're going, each of you will take turn, everyone will read 1 sentence. I tak tahu PBL dia buat macam tu. PBL hari tu buat macam tu baca sentence. Hari tu PBL, the way I run, I had my PBL last time. Kita akan, seorang akan baca 1 sentence, and then we discuss what we don't understand, what we understand, and what we don't understand in the sentence, and we decide what we want to learn from that sentence. And cues, we call it cues lah. Cues will give rise to intended learning outcome. Okay, faham tak? Okay, and then the next person will read the second sentence, and then he or she will explain what he understand, okay, and what the sentence explain, and what he mean in the sentence. Okay, what important things or topics discussed in that sentence, and then followed by the rest lah. And at the end, anything that we don't understand, we have to do homework. Faham tak? You have to read on the things that you don't understand, and then we meet up again the next session to discuss on what we plan to actually read on dekat rumah lah. Tapi for this session, you guys have to read 1 sentence and we discuss the sentence, anything in the sentence, and then follow up, and finally, hopefully towards the end, we will answer all the questions that I provided. Kan? Okay, boleh tak macam tu? Kita try kan? Kita try. So you guys will be my guinea pig lah. So I'm trying the method on you guys. And then hopefully you guys can give feedback later. Nanti I akan suruh Farah ke provide a feedback form for these 2 weeks, this week and next week. So I want you guys to give feedback on all the different method that used by all the lecturers. I want it to be constructive so that next time we can improvise. Because there's no standardization, and I believe each method at its strength has its own strength. But at the end, your learning is what most important. Okay, jap. So hold on. So let's start the first one. Case 1 where yang a mother brings her previously healthy 6-year-old son. Okay. And lagi satu kan, kalau if I'm go too far, because I just came back from my master, so the way we learn is different lah than undergrad, and definitely because I'm overwhelmed with a lot of knowledge kan, because bawa balik daripada masa usually macam houseman kan banyak knowledge daripada MO and specialist kan. So sometimes I tend to go a bit far, so you have to pull me back. Okay, or anything you don't understand, just ask, and hopefully we can finish in 1.5 hours because I've got another class at 11. Okay, so we can start. Check mana tadi? Hold on. Okay, start. So kita start dengan jap. Snap picture. Jap. Okay. Okay, so start dengan siapa ni tengah ni? Afrina Ziadi. Okay. So Afrina, okay, read the first sentence. Yang a
Okay.
mother bring the child benda tu.
Right,
Benda kita start dengan Al-Fatihah dulu, tak baca Al-Fatihah lagi. Kita start Al-Fatihah.
Okay.
Okay, read the first sentence.
Okay. So for case 1,
Hmm.
a mother brings her previously healthy 6-year-old son to your clinic because he has been limping and complaining of left leg and knee pain for 1 week duration.
Okay,
So
so what do you understand?
the
So
6-year-old son
what are the important cues in this sentence?
limping and left leg and knee
Okay.
pain for 1 week.
Okay, first from beginning kita ada a previously healthy kan?
Yeah.
Okay, so the baseline of this case is a previously healthy. Okay, boleh tak? Nurain Anis, you boleh tak scribe? Okay, you tulis So tulis cues. Okay, cues number 1, a previously healthy child. So means this child has no underlying morbidity.
Doctor, actually I'm using okay, I will transfer to laptop. So I will take
Tak
some
apa,
time.
suruh Rel Anis Syafiqah ke?
Sorry.
Tak apa, you tulis tangan tak apa. You tulis tangan tak apa. It's okay, tulis tangan pun boleh. Okay,
Yeah. Do I need to share the screen or just note it by myself first?
share screen lah.
Okay.
Boleh ke? Selalu before
I'm
this you
use-
guna apa? You guna whiteboard
we usually use Google Docs macam tu lah.
Oh, you Skype guna Google Doc? Oh, okay.
Just type through.
Boleh lah, try lah macam tu. Boleh lah, apa-apa pun boleh. Guna Google Doc semua boleh kot. Okay, sekejap ni. So, cues number 1. So, pre-morbidly healthy. Okay. Pre-morbidly healthy child. Okay, and then number 2 is a boy kan? Boy. Okay. Okay, this is a boy. Because you need to know what are the important information. When you read a case or when you come across a case kan, you need to determine what is important, what is not important. If you're not sure, then you list down. Because this can actually give you clues what is the diagnosis. Okay, so tadi you mentioned about pre-morbidly healthy child and a boy. 6-year-old. Okay, number 3 is 6-year-old. Okay lagi? Okay, what are the clues yang cakap tadi? Presenting complaint ya?
Limping and left leg and knee pain for 1
So
week.
limping and left
Left leg
leg
and knee
and
pain
knee pain.
for
for
1 week duration.
1 week.
1 week.
So 1 week. Okay, 1 week. Okay, so let's go through one by one. Okay, this is a healthy child. So when we say healthy child means this is unlikely to be something chronic lah. This is something acute. Okay, acute illness on a healthy child. Kalau contoh dia kata, okay, this is previously a child with cystic fibrosis or a child with severe asthma or a preterm infant, ex-preterm, then we know there might be some other diagnosis possible kan. Okay, so healthy child, so there's nothing in the background that can suggest, that can influence the current problem. And then boy, okay, is there anything particular in boy? Definitely lah, kalau X-linked kan, then we have to consider is this something yang X-linked ataupun something yang boy predominant illness, contoh macam ADHD, autism. Okay, these are not X-linked tapi memang boy predominant. Okay, tapi tak ada possible, tak ada kaitan lah dengan this case. And then 6-year-old, okay, the age, okay, kalau 6-year-old datang with limping, knee pain, what is the usual causes? You have to know, you have to understand the development lah kan. Kalau baby kan umur yang contoh baru jalan datang dengan limping, then you may think of, oh, possible this is actually hip punya dysplasia, TDH for example kan. Because it may not be it may be something congenital lah, structural problem. Tapi kalau 6-year-old, pre-morbidly healthy, has been running around and then suddenly datang ni, chances are this is something pain acquired. Something pain acquired. For 6-year-old, kita tahu lompat sini, possible this is something trauma, orthopedic related, or fracture, things like that. Okay. So more likely this is something yang acquired. Okay. Possible trauma in origin rather than something yang congenital or genetic. Okay, so tadi, okay, first kali previously healthy, boy, remember this is a boy. You guna apa ni? Guna whiteboard Guna apa ni?
Saya guna iPad je sebab laptop saya lambat.
Okay, tak apa. So
Boleh
ni
juga.
software iPad lah. Boleh, tak apa. I just want to know the software yang you guna. Okay, healthy boy, and then 6-year-old. Okay. And then 1 week. So this is acute. So in general, we can say this is acute, acquired illness, acute, acquired in a previously healthy child. Okay. And possible boy predominant, or possible boy has something to do with that. Sebab in any case, kalau case macam ni kan, dia akan bagi most of the thing are something yang relevant. Okay, the sex will be relevant. If not, they just say a child. Tapi sebab this mention about boy, is it something important or not? Okay, we will see. Okay, we'll see. Because I don't pick this case as for purpose, for non-purpose, because it has purpose. Okay. And then so complain dia limping and also left leg or knee pain. Okay, in pain kan, kalau lower limb pain. Okay, tadi Afina kan, Afina. So lower limb pain. So limping, what cause limping in a child?
It could be due to infection, inflammation, or malignancy.
Limping of the lower limb.
Oh, limping.
What cause limping? A child to be limp. Is it pain? Okay, so it can be because of pain. Okay. Besides that, anything else can cause limping?
Muscle disorder.
Muscle, okay. So pain, muscle disorder, okay. Muscular problem, muscle pain, atau weakness can cause limping.
Yes.
Okay, so weakness, joint pathology, can joint cause limping?
Yes.
Okay kan, joint pathology lah kan. Okay. Okay, so we know from this sentence this is something acute, acquired acute. Okay, next. Okay, next sentence. Siapa Nurain Anis Najha?
He has
baju hitam ni, masa baju hitam ni semua orang.
Sebab dia rumah.
the easiest way, Doctor. Okay, he has experienced no recent trauma and his past medical history is unremarkable. So, no significant.
So what significant?
You can exclude any differential diagnosis because of the trauma. So it's not probably because he is fell or something that caused the limping.
Okay, so not traumatic kan? No trauma.
Yes.
Okay, lagi?
And his past medical history is unremarkable. So there might not because of the any disease that contribute to the limping.
Okay,
This is
so
the first time.
Something yang underlying kan?
Okay. There's no underlying disease.
They stress on that. A previously healthy child. Okay, next sentence. Siapa lagi? Next sentence? Shamina.
Okay. So his physical examination reveals a temperature of 37.8 degrees Celsius orally with no lower extremity swelling, misalignment or weakness. Okay.
So your cues is?
The temperature 37.8 degrees Celsius, which is low grade fever.
Okay,
and then there will be no lower extremity swelling, misalignment or weakness.
Okay. Siapa? Anis Najihah yang tulis ni? Siapa yang tulis ni? Lupa dah tadi.
Anis Khairuddin.
Anis Syafiqah.
Anis Syafiqah, sorry.
Anis Syafiqah, you groupkan semua sign and symptoms into one group.
Yang Yang hijau tu negatif, yang hitam tu positif.
Okay, good, great. Okay. So temperature, low grade temperature. Lagi apa lagi tadi kata?
No lower extremity swelling, misalignment or weakness.
Okay, so dia kata no swelling kan?
Hmm.
So we can rule out apa? With no swelling, what we can rule out?
Metabolic disorders,
How is that possible?
edema maybe.
Okay, so we can rule out edema. Okay. Actually metabolic, most metabolic kan yang cause limping biasanya memang tak akan ada swelling. Okay, so usually swelling ni because of apa? Something yang quite local kan? Swelling means something yang quite local lah. Okay, so you boleh rule out things yang trauma kan? Apa lagi? Hematrosis. Remember this is a boy. Okay, this is a boy. Okay, so boy prone untuk dapat apa? Apa penyakit yang run in boy? X-link yang datang dengan problem dengan limping, joint, hemophilia lah sayang. Okay, hemophilia. Okay, you have to think of hemophilia remember, hemophilia usually comes like this. Especially yang von Willebrand disease ataupun yang non-major lah hemophilia. Kalau hemophilia yang tu datang earlier, but 6 years old, datang dengan limping, you have to think of hemophilia lah. Okay, where they presented with hematrosis. So we can almost rule out hematrosis, septic arthritis kan? Because this came with swelling lah, swelling of the joint. So no problem with joint. Okay, joint pathology we can rule out. Okay, lepas tu apa lagi? Swelling, then you kata you trauma boleh rule out. Fracture we can rule out. Can we? Fracture akan ada swelling kan? So we can rule out fracture. Misalignment also can rule out fracture, and usually misalignment mesti joint punya problem. So this is not a joint problem. Kan? And then no weakness. When you say no weakness, usually kalau weakness is associated with neuro punya problem kan? Because neuro can come with limping as well, remember So we can almost rule out neuro punya problem. So rule out neuro. Okay. Okay kan? Understand? So that's how you read a case. Okay, that's how you read the case. And definitely you need a strong basic medical sciences to actually to read a case. Okay, ada anything else yang kita miss? Anyone thinks there's other cues, important cues? Okay, rasa satisfied so far? Okay kan? So let's read the next. Okay, next apa? Nur Shazwani. Yeah, just read the nama yang keluar kat depan ni lah So nanti Shazwani, okay.
He has tenderness over the right knee, hepatosplenomegaly, and petechiae on his cheeks and chest.
Okay, so cues?
Tenderness over the right knee.
Okay, so tenderness over the right knee. Okay, tenderness. Okay, so what cause tenderness? What can cause tenderness?
It may be caused by inflammation.
Okay, inflammation, okay, can be, okay, inflammation. Cuma usually inflammation akan datang dengan swelling, okay? Arthritis, mesti ada tenderness and mesti ada swelling. And warm, kan? Mesti ada warm to touch. By palpitation ada warm. Okay, so besides that, kalau tender kan, if you got tender at your limb kan, kat limb ada tenderness, ada pain. Where can the pain arise from?
Joint.
Can arise from joint. Joint ada receptor ke? What structure can give rise to pain? Where's your pain receptor? Rest. Because ni tenderness tau. Tenderness means mesti ada pain kan? Tenderness mean pain lah. So which structure can actually cause pain? This is very important. Okay, kat mana ada pain receptor?
Bone.
Bone. Which part of bone yang ada pain receptor?
Periosteum.
Periosteum. Okay, remember So periosteum. So bila patient complain of tenderness, it can be deep structure which is bone kan? Arise from periosteum. So how periosteum boleh dirasa pain?
Nociception.
Yelah, nociception. Tapi macam ni you boleh induce pain dekat periosteum? Usually caused by stretching of the periosteum. Maksud kalau ada swelling ada something yang swell. atau ada fracture yang cause disrupt the periosteum ataupun stretch the periosteum. Okay, faham tak? So it can be from inside the bone yang pushing the periosteum, stretch the periosteum, causing the pain, ataupun it's actually something yang disrupt or fracture lah. Okay, faham? Okay, beside periosteum, apa lagi yang ada pain receptor? Your skin kan? So it can be something yang superficial or something yang deep. Okay, in general, bila kita ada tenderness, local tenderness, it can be something yang deep structure, which is usually your periosteum. Okay, something on top of periosteum pressing the periosteum, atau something be underneath the periosteum yang pressing on stretching the periosteum, ataupun fracture. Okay, yang tu akan cause tenderness. Ataupun it's something more superficial, which is the skin. Okay, the skin got receptor kan. Adipose tissue tak ada receptor So periosteum, skin ada receptor. Tapi skin kita akan nampak swelling, biasanya akan nampak swelling, akan nampak redness, kita akan nampak bruises for example kan, ada hematoma. This will cause skin ni lah. Okay, kalau dia kata pain, it can be radiated pain from elsewhere. Tapi kalau dia tenderness, it means something yang local. So nampak tak from this so far, what we can say, what actually cause the pain now? What is the problem with this child? Someone cuba try to summarize so far lah. Kita complete one sentence lah. Kita habis satu sentence. So dia ada right knee tenderness lagi. Dia ada hepatosplenomegaly. Okay. So what does it mean hepatosplenomegaly? Berapa size hepatomegaly? What is the size of liver yang kita nak kata dia hepatomegaly? Anyone? Berapa liver span yang kita nak kata hepatomegaly? What is the normal liver span now? What is the normal liver span untuk 6-year-old?
Someone 10.8 centimeter, 6 to 8 years.
So 6 to 8 years, 10.8
centimeter.
That's a bit specific. So tak 10 to 11 lah kot. Kita tak 10 to 12 or 10 to 11 lah. Okay. About 10 cm. Okay. So remember kalau 6 to 8 years old Okay. So apa je punya reference? Reference siapa?
Healthline.
Huh?
Healthline.
Google lah Okay, tak apa. So 6 to 8 years old. No, tulis lah kat sini. Kat situ. Hepatomegaly bawah ni tulis. Okay, in a child of preschool age, usually the liver span is about 10 cm. Okay, 10 to 12, 10 to 11 cm. So more than that, more than 12, more than 11, kita kata hepatomegaly. Okay, tulis lah kat sini. Normal liver span for preschool is about 10 cm. So more than that is considered ni. Okay, splenomegaly. What is the normal spleen size untuk 6-year-old? Normal spleen, cepat 6-year-old.
9.5 centimeter for 6 years old.
Okay, so kita letaklah. For preschool, normal spleen is about 9 to 10 lah. 9 to 10 cm. Okay, this is normal untuk preschool Okay, so hepatosplenomegaly means both. Now dia ada both hepatosplenomegaly. Okay, what condition cause both hepatosplenomegaly?
Infection.
Infection. Okay, what sort of infection? Okay, how it works? Okay, biasanya when we have something, a pathology, okay,
Yes.
ataupun a disease atau a problem, try to be systematic in determine the etiology. Okay, usually my suggestion is we use the vitamin A, B, C, D. Tahu kan? The acronym vitamin A, B, C, D, E, F, G, H, I, K, L sampai Z. Tahu tak? Pernah dengar tak? Tak pernah dengar? Okay, so buat macam ni, hepatosplenomegaly. Okay, you pecahkan the etiology, buat branch macam atas ni. Buat branch. Okay, tulis vitamin A, B, C, D. VITAMIN ABCDE. Bukan V, I, buat branch. Ni acronyms. Buat je kat sebelah ni. Panjang ke sebelah, buat V. Bukan semua akan ada, tapi most akan ada. V, I, G. Okay, so let's look at V. These are all etiologies tau, etiologies. So V, okay, V is vascular problem. What vascular problem can give rise to hepatosplenomegaly? Ada tak vascular problem, something to do with your vessel yang boleh cause hepatosplenomegaly? Ada tak? Anyone can think of? Okay, for example, kita boleh dapat portal vein thrombosis. Okay? Kalau you ada portal vein thrombosis ataupun you ada apa dia? Yang cause caput medusa, chronic lung disease lah. Problem lung disease. Problem dengan liver. Hypertension.
Portal hypertension.
Portal hypertension. Okay, so portal hypertension, portal vein thrombosis, or anything at the level of obstruction at the level of superior vena cava, inferior vena cava. Faham tak? Yang sepatutnya liver dan spleen akan drain out, tapi dah ada obstruction. So any obstruction at that area will give rise to hepatosplenomegaly. Vascular causes. Infectious. Infectious causes. Apa yang cause hepatosplenomegaly? Infectious.
Hepatitis.
Hepatitis, does it cause splenomegaly? Hepatitis? No, hepatitis tak cause. Unless kalau dia dah jadi liver cirrhosis, dia akan cause splenomegaly because of portal hypertension. What infection can cause hepatosplenomegaly?
Infectious mononucleosis.
Okay, infectious mononucleosis, that's better. Okay, ataupun EBV lah. Infectious mononucleosis is the disease. Okay, the etiology is EBV. So it is EBV. Okay, what else? What other infection can cause hepatosplenomegaly? Faiz, Fat.
Parasite.
Malaria cause hepatosplenomegaly.
Parasite in origin.
Okay, good. What type of parasite?
Cystostoma japonicum.
Oh, interesting. Okay. Does it really cause hepatosplenomegaly?
Spleen and I'm not sure.
Tu rasa you kena check. I rasa dia cause splenomegaly. I rasa dia cause splenomegaly. Dia cause hepatomegaly
I can't remember. It's either liver or spleen. I'm sorry. It's a bad example.
No, it's okay. Search lah. So someone else yang baca lah. While we discuss, kena ada seorang yang search. Okay, causes of hepatosplenomegaly. Infectious causes. Malaria, can malaria cause hepatosplenomegaly?
Yes.
Hepatosplenomegaly, malaria. Boleh tak?
Boleh.
Okay, then malaria. Letak malaria. Okay, infectious cause of hepatosplenomegaly. Cuba check internet. Okay, protozoa boleh. Protozoa macam tu malaria, kalaza, amoeba, toxoplasma, this can cause lah. Okay, toxoplasma, yang tu, tapi tu these are very rare lah. Okay. Tak apa, itu istilah parasites. Malaria parasites can cause. And then bacterial, TB can cause hepatosplenomegaly. Brucellosis, syphilis, these are zoonotics. Helminths, okay. Fungal histoplasmosis. Kalau azar lah tu yang tu cerita. Okey lah, itu je lah. Infectious ni banyak sangat so tak ya, tapi most likely tak lah pun. Okay, T is trauma. Trauma boleh tak cause hepatosplenomegaly? No lah. So T ni there's no. Trauma no. A is apa A? A is what? A is what is A? I tak ingat lah A. Tak ingat lah A, tak apa. Skip tu. M is malignancy. Macam salah je. Sekejap lah. Tapi dah lupa lah.
Doktor, yang tadi tu A autoimmune.
Autoimmune. Okay, autoimmune. Apa autoimmune causes yang cause ni? Yang cause hepatosplenomegaly. Boleh tak autoimmune cause hepatosplenomegaly? What type of autoimmune? Actually, most autoimmune cause hepatomegaly lah. But definitely splenomegaly can be caused by autoimmune. Letaklah SLE boleh kot. SLE letak je SLE ke. Okay. Lagi apa lagi? What else? Which autoimmune can cause hepatosplenomegaly? Tak ada kot. Okay, malignancy? Malignancy kan?
Metabolic.
Metabolic. Apa metabolic? Metabolic banyak ni. Apa metabolic cause?
Gaucher's disease.
Gaucher. Okay, lagi?
Niemann-Pick disease.
Niemann-Pick is
Involving
LSD,
fat accumulation.
Niemann-Pick is bukan LSD ke? Lysosomal storage disease. Fat dia kata apa? Niemann-Pick?
Fat accumulation in the cell.
Yelah, Niemann-Pick tu yang tu dia punya pathology, tapi dia punya type tu tak apalah, start je. Gaucher is a type of apa? Gaucher is what?
Genetic condition that cause fat accumulation in different organs and cells.
Okay lah, Gaucher is LSD lysosomal storage disease. So Gaucher is usually lah, hepatosplenomegaly will be caused by lysosomal storage disease ataupun glycogen storage disease. So you touch tu LSD, lysosomal storage disease. Contoh macam Gaucher, macam Niemann-Pick ataupun glycogen storage disease. Contoh macam Van Gerke, GSD type 1, type 1A, type 1B. Okay, GSD apa lagi? Yang cause hepatosplenomegaly, metabolic memang banyak lah. Pompe tak cause ni. MPS akan cause juga hepatosplenomegaly. MPS lagi satu. MPS boleh cause hepatosplenomegaly. Mucopolysaccharidosis. Yang ni memang banyak lah. Yang ni tak payah sebut. Okay lah. Ni banyak sangat. Unlikely lah in this case. So these are all chronic condition lah. Tapi GSD dia usually very well lah. No, luar dia nampak normal GSD. Tapi dia ada problem dengan hypoglycemia. Apa metabolic lagi? Vitamin I. Idiopathic kan? So tinggallah idiopathic ni. Maksud dia you tak tahulah benda apa. So vitamin N neoplasm. Boleh tak? Which neoplasm can cause hepatosplenomegaly?
Lymphoma.
Lymphoma. Okay, good. Lymphoma. Lagi?
Leukemia.
Leukemia can, of course. Leukemia. Good. Lagi? Apa neoplasm can cause hepatosplenomegaly? A lot of neoplasm cause hepatomegaly, tapi actually not many cause splenomegaly. In fact, usually splenomegaly is results due to obstruction dekat liver punya level. Because you have to understand, you punya spleen, they drain to the liver tau. The drainage is, they share the same drainage, okay, with the liver. So bila liver congested, dia akan cause splenomegaly. So lymphoma, leukemia, what else? Apa lagi neoplasm can cause ni? Ni lah metastatic lah, tak metastatic. Usually liver memang cause metastatic ni lah, tapi spleen ni jarang dia metastasize to the spleen. Okay, lagi next apa lagi? Vitamin A apa A? Atas autoimmune.
Alkohol.
Alkohol. Okay, alkohol boleh tak? Alkohol. 6 tahun, so tak payah tulis lah, buang je lah. B, blood kan, blood disorder. Apa blood disorder yang can cause ni? Hepatosplenomegaly, ni tak tahu nak cakap apa.
Thalassemia.
Thalassemia, good. Okay, so thalassemia. Thalassemia lagi?
Sickle cell anemia kan doktor?
Sickle cell lah. Sickle cell, diorang tak datang macam ni. Dia datang dengan trombosis. They can, kalau dia ada portal vein thrombosis, dia akan ada ni. Boleh lah sickle cell. Tapi by that time, dia in severe pain. Siapa pernah jumpa sickle cell kat sini? Oh, disaster lah. Ni memang disaster lah sickle cell. Diorang akan jerit all the time. Diorang in pain like hell. So kalau you've got one sickle cell in crisis datang kan, during your call, nurse akan call you every 1 second dia akan call. Doktor, patient sakit. Doktor, patient sakit. Doktor, patient sakit. Oh, memang disaster lah. Tak suka sickle cell. Lagi. A, B, C. C what? C.
Congenital.
Congenital. Could this be congenital? Unlikely lah kot. So tak apa, kita ignore je. D?
Degenerative.
Degenerative. Could this be degenerative? No lah. Degenerative has to be something chronic. Something chronic and dia downgoing lah, downhill slowly. Okay, so these are the causes lah of hepatosplenomegaly. Okay, next apa lagi? Apa lagi Q saya ni? Lepas hepatosplenomegaly, what else? Dia ada apa?
PTK on his cheeks
on cheek and chest. Okay. What cause PTK? What is PTK? Before that, what is PTK? Shazwani, what is PTK?
Tiny circular non-raised patches that appear on skin or in mucus or serous membrane.
Okay, so syarat dia, how to call it PTK, it must be tiny. It must be tiny. Berapa size PTK?
Less than
This is
3.
important now. This is very important. Less than
3 millimeter.
Clear dia kata. Okay lah, tak apa. Clear. I rasa macam 5 tapi tak apa. Small, less than 3 millimeter. Okay, if more than 3 kita panggil apa? Purpura kan? Purpura sampai berapa cm? Cepat. PTK, purpura. Kalau besar dia purpura, jadi apa?
Ecchymosis.
Ecchymosis kan? Purpura berapa cm? This is very important because later when you describe patient, you have to be specific. So you akan cakap, oh patient noted have from physical examination noted patient have purpura at kat mana? Dekat terang. Okay, it's a blanching purpura. Ataupun kalau besar sikit dia purpura, it's called ecchymosis. Presence of ecchymosis at the lower limb. So purpura berapa cm?
4 to 10 millimeters.
Kan dia less than 1 cm. Ingat purpura less than 1 cm. Okay, sekarang ni dia ada PTK. Okay, what cause PTK? Okay, remember PTK, can it be raised or does it has to be flat?
Flat.
Flat kan? Ya ke? Boleh tak raise PTK? Boleh PTK actually boleh raise. It doesn't matter, it can be raised. Okay, especially macam HSP, most of them it raise PTK. And then dia blanch atau tak blanch, okay? Okay, so dia kata ada PTK. What cause PTK? Nakib, what cause PTK?
No.
So what cause PTK?
PTK caused by the blood leak from the capillaries.
Okay, usually capillary punya bleed lah. Okay, PTK is caused by capillary punya bleed. So usually dekat mana yang banyak capillary? Dekat mucosa lah, usually mucosa kan, superficial skin. Dekat ear, okay, dekat ear. That's why you dapat telangiectasis. Mucosa, ear, skin. Okay, you don't get PTK, dia tak ada deep PTK. Kalau dia bleed dekat deep structure, it won't cause petechiae lah. Okay. Okay, so next sentence. Habis dah kan? Okay, habis. Okay, so how do you approach the case? So macam mana you approach the case? So this child datang jumpa you, mother came to you. Okay, again let's see. So mother came to you, bring with her a healthy 6-year-old son. Okay, previously healthy 6-year-old son, datang limping. Okay, how do you approach the case? Apa yang you kena buat dulu first? You kena kelak lah kan. Okay, approach of the case always start with history taking. So what sort of history yang you kena tanya? Okay, let's start with. Sebab kita habis tengok semua ni lah, semua attendees lah. Macam mana nak tahu siapa only participants ya? Okay, siapa yang tak cakap? Okay, Arar Mabam. Okay. What question you want to ask?
I want to ask about family history.
Family history specifically?
Whether there is any sibling that have leukemia.
Okay, ask me the question. Okay, Arul, ask me the question. Pretending I'm the mother. Okay, how are you going to ask family history?
This child have any sibling that have history of acute lymphoblastic leukemia?
No, I don't have any. This is my only son. I don't have any other son or daughter with leukemia. What else?
This son have twin?
No, this is my only son. Tu je nak tanya. What else? Family history.
Any history of this son have lethargic when feel tired when do activity.
No, family history kan? Let's focus on family history. What else you want to ask? Family history. Takkan you tanya leukemia?
Is there any history of Down syndrome?
Okay, syndromic child. Okay. Why is it important?
Because the prevalence of ALL is higher in children that develop Down syndrome and Fanconi anemia.
Okay, that's true. Tapi is it, kalau siblings ada Down syndrome, does it increase risk of other siblings to get leukemia?
Maybe we have to check for the sign of the Down syndrome and Fanconi anemia in these children too.
In this child? Okay, good. Boleh lah, accept lah. Okay, lagi. What else family history apa you nak tanya? You tanya broader lah, you tanya any malignancy tak dalam family? Ada keluarga yang ada cancer ke tak? Ada yang mati waktu kecil for no reason mati, ataupun because sometimes ada cancer tapi dia tak seek treatment so mati kat rumah. So early childhood death, dia boleh tanya malignancy, pasal apa lagi? Okay, consanguineous, does it important?
What?
Consanguinity, does it important? Is it important to ask consanguinity?
Important?
You can ask consanguinity. I don't think it's important in this case, tapi you have to ask. Anyway, you have to ask. So ask about consanguinity. Okay, what else? Apa yang you nak kena tanya? Now you are taking history from the mother. What else you want to tanya? Faiz?
That's about the current illness, HOPI.
Okay, so apa yang nak tanya?
Chief complaint is about pains. So maybe we talk about, does she seek any treatment for the complaint previously before coming to this hospital?
No, because my child, no, I haven't been to any doctors this first time because it's only 1 week, and I thought he just felt like he fall or something, but because this last yesterday he complained increase in pain, and he can no longer walk at all, so that's why I brought him today. Lagi apa you nak tanya?
As about the pain, so does it increase intensity over time?
Okay, lagi? No.
Then,
It is. Yeah, it does. Okay.
then does the pain occurs continuously or intermittent?
It's intermittent. It was in the night and morning, early morning. Okay.
Then talk about whether the pain caused if the pain occurs during resting or when there's movement.
All the time. I mean, doesn't related to movement. Because during sleep also pain, the child will complain pain. In fact, it was during night lah. Okay. So you tanya the Socrates lah. Okay, when you've got any pain, you tanya the Socrates. Tahu Socrates kan?
Oh.
So what are the Socrates? Side?
Side.
Okay.
Okay. Onset.
Onset, good. Again.
See characteristic of the pain itself.
Okay, characteristic. So it's a throbbing. Is it throbbing ke? Is it sharp pain ke? Kan? Okay lagi?
Radiation. Does it radiate to other places?
No, just at the knee. Okay.
Alleviating factors.
No.
Do something to alleviate the pain.
No, nothing.
So regardless of do anything, the pain's there. I think time.
T apa T?
Time.
Time. Okay, time apa?
Duration.
Duration kan? Okay, duration dah 1 week. Lagi? E, alleviating factors. S?
As associated symptom.
Okay, so itulah I dah mention tadi kan, associated symptoms in the case. Okay, so that's it. Okay, so first approach is history taking, and then physical examination. Physical examination, what do you want to look for in this case? Remember, 70% of diagnosis should only come from your history. A good history should provide you 70 to 80% information for determining the diagnosis. So Nurul Aiza, what do you want to look for during your physical examination?
First, the general appearance.
Okay.
And
especially, what do you mean general appearance? What do you expect to see in
anemia.
Okay, pelo kan? So pelo lagi?
Yeah.
What else? So is the child active? Do you expect the child to be active?
Less.
Okay, so the GCS, remember the conscious level you have to determine during your physical examination. So general appearance, color kan, color, all the ABCD lah. Okay, general appearance, okay, lethargic ke conscious level. Okay, lagi? Apa yang you nak tengok? What do you want to examine specifically in this child? Apa yang nak tengok?
Dia dah mention tapi vital signs.
Vital sign, okay, vital sign dimension lagi. What else? I don't want to ask your suspicion, but you should have a suspicion now. After you read through the case, after the discussion, you should have your differential in your brain. So you have to find clues to support your diagnosis or to rule out your differential diagnosis. So what clues you want to look for from physical examination? Lagi apa lagi? I tak tahu apa yang you punya, I mean you punya diagnosis now, tapi what you want to look for? Apa lagi?
Bruising.
Bruises, okay, lagi? Anyone?
If
Good bruises.
the any mediastinal mass.
How do you want to know mediastinal mass? From physical examination?
Palpation.
Macam ni nak palpate mediastinum? Kan ada sternum kat situ. Nama mediastinum.
Okay. Ask
Percussion
if.
mungkin boleh lah. Percussion mungkin boleh.
Oh.
Okay, percussion lah. Okay lah, percussion. Tapi orang tak buat lah. Okay, lagi-lagi. So, mediastinal mass usually is actually deep mass lah. Rather than, except for thyroid, the rest are actually in the middle and posterior compartment rather than anterior compartment of your thorax. So you won't get to percuss anything because most of them are actually beside in the middle of the lung or behind the lung, not on top of the lung, except for thyroid and thymus. Dua tu je yang ada dekat anterior compartment of your thorax. So only these two yang you boleh palpate kalau dia enlarge. Okay. Kalau you rasa lymph nodes, then you won't be able to percuss or palpate. Percuss lah, sorry, percuss. Okay, apa lagi? Cepat. Apa lagi? Rasanya satu case ini. Tak apa, satu case ini. Lymphadenopathy, good. Dekat mana you nak check?
Dekat around neck area.
Neck lagi? Neck, is it neck alone lagi?
Posterior auricular.
Posterior auricular lagi? Okay, neck lah. Senang cerita dekat neck. Lagi dekat mana? Axilla. Lagi? Groin. Okay, this is the main lah. Okay, apa lagi? Lymphadenopathy. Lagi apa lagi? What else? You need to look for rashes, okay? Rashes. Especially blueberry muffin rashes. Mana dengar tak blueberry muffin rashes? That's why you kena baca baru you tahu you want to look for. What you want to look for. Rashes, you have to look for rashes. Okay, apa lagi? Apa lagi? What else? You have to look for gum hypertrophy. Okay? Don't narrow your diagnosis. You have to, not too broad, but yet not to exclude, not to miss anything, something that is important lah. Look for gum hypertrophy. Okay, lagi apa lagi? Apa lagi? You kena check for testis. Okay? Check the testis. This is a boy. You need to check the testis. What you look for?
Swelling.
What sort of swelling? Apa yang swell? Okay, you have to look for painless enlarged testis, okay? Hard testis yang painless. Okay, apa lagi? Apa lagi you have to examine? The rest lah, neuro exam you kena examine, definitely. And then apa lagi? Okay, yang tu je lah, mainly itu je lah. Okay, so next question. Okay, so you dah ambil history. Okay, explore the HOPI. Okay, ask other relevant history. Examination, it has to be guided. Examination has to be guided. You have to do all system examination, definitely. Tapi you have to be detailed, do detailed examination based on your, guided by your diagnosis or your differential diagnosis. Okay, next question is, can you explain the physiological changes that is causing the sign and symptoms? So what actually caused the sign and symptoms? Now look back at the sign and symptoms. Mana list sign and symptoms tadi? Yeah, okay. Okay, look at the sign and symptoms. First, knee pain. Okay, what explain the pain in this child? Most likely, what caused the pain?
Bone pain.
Okay, this is a bone pain kan? Okay, this is a bone pain. Okay, what caused the bone pain? Macam I cakap, the pain in the bone originates from the periosteum kan? So what caused periosteal pain in this child?
When there is any bony expansion.
Bone expansion kan? Marrow lah, especially marrow expansion. Bone expansion can be, yalah, it can be due to the bone itself. Ataupun the marrow lah inside. So in this case, what do you think? Is it the marrow or the bone? Could this be osteosarcoma ke, Ewing sarcoma ke? Or is it something to do with the marrow?
Marrow, something to do
Marrow lah
with
kan?
marrow.
Because there's a lot of systemic signs and symptoms kan? Then chances are this is something to do with marrow. So we've got clue now. What explains the pain is actually the expansion of the marrow causing the stretching of the periosteum that leads to pain. Okay, apa lagi? Apa signs and symptoms? Okay, 1 week. So this is something acute. Okay, something acquired, acute. Okay, lagi apa lagi? No
Fever.
trauma, no past. Okay, fever. What caused the fever?
Infection because of the pancytopenia, maybe. Anemia.
Anemia doesn't cause infection, does it? Temperature 37.8, not that high. Could be, yes, it could be infection. Okay, superimposed infection because of maybe marrow punya problem atau weak immunodeficient kan, causing infection. Good, okay, boleh. Besides that, can be inflammation lah kan. Okay, you got inflammation occurring. Okay, remember malignancy is can cause inflammation, can cause thrombosis. So this can actually trigger inflammation, can cause fever lah. Okay, lagi apa lagi? No misalignment. Okay, ni semua negatif. Apa positif ni? Right knee tenderness. Okay, you mentioned tadi kan. Due to bone pain lagi.
Atau splenomegaly.
Okay, splenomegaly due to?
Due to the
All the
infiltration.
etiology. Among all the etiology kan, yang vitamin A, B, C, D, which one yang you rasa boleh explain all the findings?
Neoplasm.
Neoplasm lah kan. So we can pinpoint this is actually neoplasm lah. Can metabolic causes cause this? Metabolic causes rarely cause fever. They can come with fever lah kalau dia in crisis. Tapi these metabolic causes yang cause hepatosplenomegaly are usually chronic condition. They don't come with fever. They come with crisis, ada metabolic crisis lah. GSD tak cause fever, MPS tak cause, Gaucher tak cause, ni semua tak cause fever. These are chronic. So metabolic can rule out. Autoimmune, does it cause fever? Yes, of course it cause fever because autoimmune memang datang dengan fever, inflammation. Tapi this is chronic lah. Autoimmune usually is something chronic, bukannya acute. Then kita boleh buang autoimmune. Apa lagi? Vascular, unlikely lah cause fever. And tak ada risk in this child. Infectious, can infectious be the diagnosis? Not many of this infection can actually present with pain lah kan. Okay, TB can present with pain dekat lower limb. Apa? Biasanya apa yang TB? Tapi apa yang akan ada? Kalau TB datang dengan pain lower limb, biasanya apa yang akan ada? Apa sign yang akan ada kan? Dekat lower limb punya TB. Susah tak banyak sekali. Apa nama makhluk tu? Lupa lah. Yang warna purple kat kaki tu. Apa nama dia? Apa nama dia? Alah, tak ingat lah. Yang TB tu, yang kat kaki tu. Ni dia. Bukan. Yang dekat kaki tu, dekat shin tu. Apa nama findings dekat shin yang TB tu?
Gangrene?
Bukan.
Varicose.
Bukan.
Okay.
Tak apa, abaikan nanti saya tengok beritahu. Okey, tak apa, abaikan. Okey. Blood disorder, can thalassemia cause fever? No kan? Tapi dah ada hepatosplenomegaly. So your main diagnosis now is actually leukemia lah. Okay. PTK. Okay, what explain how PTK occur in this child? Because of How to explain petty K in this child?
Thrombocytopenia.
Okay, what cause thrombocytopenia in this child? Kenapa dia
Maybe
ada
bone marrow
thrombocytopenia?
infiltration.
Okay, so bone marrow infiltration. So what happened bila bone marrow infiltrates?
Platelet reduction.
Dah. Okay, what cause platelet reduction?
The blood displace the blood precursor, the other blood precursor, and cause the
Okay, pandai.
thrombocytopenia.
Okay, so this is what you call, you have to understand the, apa dia? The hematopoiesis kan? Dia punya, apa namanya? Hematopoiesis. Yalah, hematopoiesis lah. Kan? So, you punya hematopoiesis, what happened in your hematopoiesis? It's divided into you punya myelopoiesis dengan leukopoiesis kan? Kan? Myeloid dengan lymphoid kan? Okay, myeloid and lymphoid. So what happened in myeloid? You ada common precursor. You ada common precursor lah. You ada common precursor cell. These are the progenitor kan? This is multipotent stem cell kan? Okay, you ada multipotent stem cell. They differentiate into lymphoid precursor dengan myeloid precursor. The same myeloid precursor will differentiate into further. Jadi apa?
Small lymphocyte and natural killer cell.
Tu lymphocyte. Lymphocyte precursor dia akan jadi mature lymphocyte dengan natural killer cell. The myelocyte akan jadi apa?
Red cells, platelets.
Good. So the myelocytes dia akan jadi dia akan jadi apa tu? Dia punya give rise to you punya RBC, apa nama dia? Lupa dah lah. Anyway, so dia akan jadi leukocyte kan? Leukocyte akan pecah jadi dia punya neutrophil, eosinophil, basophil, and then dia akan jadi dia punya megakaryocyte, akan give rise to your platelet. Kan? Erythrocyte akan give rise to your red blood cell. So these all come from a common precursor. Kalau dia jadi blast banyak sangat, kan? If the common precursor they differentiate into white blood cell, into leukocyte punya blast, kan? Ataupun the progenitor cell dia jadi banyak sel lymphocyte, then what will happen?
You will suppress the other normal hematopoiesis.
So that's why dia dapat thrombocytopenia. So thrombocytopenia in this case not because of destruction, it's usually because of reduced production. Okay, reduced production of platelet leads to thrombocytopenia, anemia, and so on. So your final diagnosis is?
Acute lymphoblastic leukemia.
Why is this is ALL?
Because of the age is
What
common.
could be AML?
Oh.
AML most common in adults, right?
No. Of course, most common in adult, tapi pediatric pun dapat AML.
AML usually comes with gum hypertrophy.
Not necessary. AML, okay, ada berapa banyak AML you tahu? How you divide AML? How you differentiate AML? Dia ada 2-3 classification lah, but the simplest one is the WHO M0, M1, M2, M3, M4, M5, M6, M7 kan? Based on you punya progenitor, you punya myeloid punya origin lah. Faham? Lymphoid. So ALL divided into?
B-cell and T-cell.
B-cell. Okay, in general you divide into B and T lah, and then B you can divide further. BLL you can divide further based on FAB punya classification lah. Okay, dia ada banyak classification, but in general you divide into common, pre-BLL, common BLL, and also you ada mature BLL kan. Pro BML, dia BLL, pro BLL, pre, and ada banyak lah. So in general, this you cannot rule out AML lagi, faham tak? You can only rule out BLL. You can just say this is a leukemia, but you cannot say this is not AML. Because not all AML akan datang dengan hypertrophy. Okay, each AML dia akan ada dia punya features lah. It can be M7. Okay, or M1, M2, M3 doesn't matter. Okay, so what investigation you want to So we can commit this is something leukemia lah. So the diagnosis now is leukemia, acute leukemia. Okay. Okay, this is acute leukemia. Can agree? Ke ada anyone got any other diagnosis? Anyone not agree with acute leukemia or any other diagnosis yang you think is possible? Okay, I rasa semua agree kan? So investigation, what investigation you want to send now?
Blood count.
Okay, full blood count. Okay, what do you expect? Siapa cakap full blood count? Ain. Okay, full blood count. What do you expect in the full blood count?
Reduce hemoglobin maybe.
Okay, anemia. Okay, lagi. More important than that.
WBC will be hyperleukocytosis of the blood cell.
Okay, it's not necessarily hyperleukocytosis, tapi they need to have leukocytosis. Okay, how do you define leukocytosis?
Less than 1.0 times 10 to the 10.
That is leukopenia. Leukocytosis.
Wait.
How do you define leukocytosis?
More than 200 times 10 to the power of 9. I'm not sure.
Hyperleukocytosis. Yeah, more than 200.
Wait, I try to confirm it.
Okay, check leukocytosis. Anyone? What is the cutoff point to say this is leukocytosis? What is the number? Magic number?
11 times 10 to the power of
Okay, remember?
10 to the power.
Okay, leukocytosis is just 11, more than 11. So anyone datang dengan 20 can be leukemia, remember? Doesn't have to be 200. 20, 30 can also leukemia because the definition is blast. It's not the number of total white, it's the number of blast. So any leukocytosis. But we will highly suspect if they datang dengan hyperleukocytosis. So what is the definition of hyperleukocytosis? Leukocytosis means more than 11. Okay. Most of the time it'll be more than 50 kebanyakan masa. It may not necessarily become hyperleukocytosis, but it usually more than 50. What is hyperleukocytosis? Berapa cut-off point hyperleukocytosis?
Greater than 50?
More than 100 Okay, hyperleukocytosis more than 100. 100 times 10 power of
9.
9 The power of 9 salah, I pun tak ingat lah dia punya unit. Tapi more than 100 lah. Okay. More than 100 boleh terkena hyperleukocytosis. Okay, lagi apa lagi? What do you expect the finding will be? Especially the PTK, so platelet will be?
Low.
Low lah kan. Low means less than? Low means less than 150 is low. Tapi usually you want to get PTK, you need to be less than 50. Less than 30 biasanya dapat PTK. A lot of time dia datang dengan single digit lah. Okay, tapi low platelet defined by less than 150. Okay, apa lagi FBC? One Nushad Sony apa? Apa investigation you nak tahu lagi? Lagi satu. FBC kan, apa lagi you boleh nampak daripada FBC? You boleh hantar differential count lah. Okay, dia you rasa total white dia mainly neutrophil ke lymphocyte?
Lymphocyte. High.
Okay, usually is leukocyte lah. Kan leukocyte atau lymphocyte lah biasanya. Okay, most of the time dia lymphocyte. So it can give you idea this mostly is ALL lah, lymphocyte kan. Tapi the problem is kalau you ada myeloblast, they will look like a lymphocyte. A myeloblast will look like lymphocyte. So usually kalau you kena machine, they will report it as lymphocyte. Tapi it's actually a myeloblast. Cuma dia nampak macam lymphocyte. Okay. So apa lagi? FBC lagi? Apa yang nak hantar tadi Syazwani?
Bone marrow aspiration.
Before that.
Blood film, doktor?
FBP kan? Full blood film. PBF ataupun FBP. So what do you expect to see?
I just want to find the outright just to exclude the AML.
Okay, aurot. Okay, good. What is aurot?
Aurot is the
granules, formation of granules.
Okay, bentuk dia macam mana aurot ni?
a pink, round or root shape, splinter or jack straw.
Okay. Lepas tu, you nampak dekat mana? Nampak dekat white cell tu lah kan? Okay, myeloid dia akan ada aurot. Okay. Aurot, ada je aurot, you can diagnose AML lah. Okay, lagi-lagi? What else?
Hypercellularity
Hypercellularity of what?
of blood cells. Kalau AL, more than 20%. Kalau nak diagnose.
Okay. Dia tak sebut hypercellularity lah. Usually just measure the blood cell lah kan. So you have to look for specifically for blood cell. Okay. Kalau blood cell more than berapa persen baru you kata dia leukemia?
Kalau ALL, more than 20%.
For AML? Tak ada. Dia tak kira AML atau ALL. Okay. If blast more than 20%, you akan kata this is acute leukemia. Okay. Acute leukemia means dia ada blast lah. Okay. You nak tahu dia AML, ALL, satu je cara. You kena buat bone marrow. Because from FBP, it's very difficult to differentiate AML, myeloblast dengan lymphoblast. It's very difficult. It's not easy. Okay. So, lagi apa lagi? FBP, you nak tengok blast. Okay. First, you nak tengok blast. And then you nak tengok aurot. Aurot lah. Okay. You nak tengok aurot. Okay. Lagi apa lagi you nak tengok from FBP? Itulah mainly tu je lah. Okay. Apa lagi you nak hantar? Next, you nak hantar apa? You hantar bone marrow lah kan. You nak buat BMA. Apa yang you nak hantar dengan BMA tu? Aspirate tu you nak hantar for apa? Satu case lah kita ni. Okay, so you buat BMA. Next step investigation is BMA. This is for confirmatory. Okay, what do you want to send BMA for? You nak hantar apa BMA? You ambil aspirate marrow dia, lepas tu you nak hantar apa? So kebanyakan student kan, bila kita what investigation and what is your expected findings? BMA. BMA is not an investigation. Okay, BMA is a procedure. BMA. Macam saya, what is investigation? Ambil darah. Venipuncture. Itu bukan investigation, itu procedure. Investigation is FBC, FBP, platelets count, that is investigation. So BMA is bone marrow aspiration, it's a procedure. So what investigation you want to send?
Microscopic study.
Microscopic. What you want to look for?
Cellularity.
Okay, you look for marrow hypercellularity. Okay lah, boleh lah, tapi tak tepat. Okay, lagi-lagi, what else? What else? Specifically, you nak hantar untuk apa?
Immunophenotyping.
Immunophenotyping. Okay, what is immunophenotyping? Okay.
To check the lineage of the cell.
Okay, by? Macam mana immunophenotyping can help you to determine the lineage of the cell? What are you doing in immunophenotyping? What are we doing actually?
To see the cell surface markers.
Good. Okay, faham tak? To know whether the cell belong to which cell, I mean, if you get, contohlah, I bagi you satu sampel. Macam you nak tahu sampel ni daripada tangan ke, daripada kaki ke, jantung, hati, daripada marrow, oh ni this is a tissue of eye, ataupun this is a cell of red blood cell ke, white blood cell ke. How do you know? You need to look at the surface marker lah, the surface protein. Okay, surface marker. This is how to know what cell is this. So that's why we send for immunophenotyping. You have to stain and you buat, there's a two method lah. In general, we do two method. Kita boleh buat flow cytometry atau kita buat PCR. Okay, but usually immunophenotyping kita buat flow cytometry. Okay, so immunophenotyping is the investigation. Okay, the method is flow cytometry ataupun PCR. So you will determine how many of the blast, yang ambil the blast, you determine how many of the blast yang ada different surface marker. So contoh kalau this is ALL, biasa dia ada B. Kalau this is BLL kan, dia kan ada
CD10.
CD10 is a common BLL. Kalau CD10 is color. Tak apalah. Okay, so CD10 is color positive, is a common BLL. So CD10, CD17, ingat dah. CD20. These are all B marker lah, TDT. Yeah, tapi you tak payah memorize pun all these things. Okay, so immunophenotyping. Lagi apa you nak hantar lagi? Immunophenotype. Lagi you nak hantar apa lagi? Daripada aspirate tu, you nak kena hantar, dia punya cytogenetic. Okay, second is cytogenetic. Because this is to determine the mutation. Okay, cytogenetic you nak tengok apa? Ni I see belajar kan waktu undergrad, waktu first 3 years.
Chromosome.
Chromosome you nak hantar untuk apa? Look for?
Numerical structural abnormality.
Okay, usually kita tak tengok. Usually untuk kromosom, kita tak hantar ni, kita tak, we look for structure, tapi biasa kita akan hantar for specific lah. First kita buat karyotyping. Okay, cytogenetic kita hantar for karyotyping. Why do you want to look for karyotyping? Kita nak tahu dia euploid ke, diploid ke, aneuploid ke, triploid ke. Kenapa? Kita nak tahu dia ada berapa kromosom. Is it 23 or is it 46 or is it 90 something? So
to determine prognosis.
Yes, to determine the prognosis kan. The more the better. Remember, the more the better. The more normal, the poorer prognosis. Okay, because we want the cell to be more different. The more different the cell, the better for our immune system to detect and the better respond to chemotherapy lah. So cytogenetic, first you kena hantar karyotyping. Lepas tu apa you kena hantar? Apa yang you nak tengok? Specific mutation yang you nak tengok.
Philadelphia chromosome.
Philadelphia. What is Philadelphia?
Translocation of chromosome 9 and 11.
Translocation chromosome?
9 and 11.
9, 11. Okay. Atau nama lain dia lah. Apa nama lain dia?
BCR-ABL.
Okay, BCR-ABL. So remember So you hantar untuk presence of Philadelphia chromosome. Okay, Philadelphia chromosome is a very short chromosome because it's a chromosome, it's a product of translocation of short arm between chromosome 9 and
22.
9 and
22.
22, sorry.
9 and 22. Bukan 9 and 11 dia 9 and 22. So bila short arm 9 dan short arm 22 dia combine, dia akan nampak ada satu extra kromosom, short chromosome, Philadelphia chromosome. BCR dekat 9, ABL dekat 22. So BCR dekat proximal 9, ABL dekat proximal 22. So bila dia combine, dia akan hasilkan protein BCR ABL. Faham? Tu yang kita panggil dia BCR ABL. Okay, faham? So kalau dia ada Philadelphia chromosome, what does it mean?
Poor prognosis.
Okay, salah that's not right. Kalau this is ALL with Philadelphia chromosome, this is poor prognosis. But if this is AML with Philadelphia chromosome, it is a good prognosis. Faham? In fact, Philadelphia chromosome diagnose AML. Okay, faham tak? Okay, what else? Okay, settle dah. So our diagnosis now is, okay, what else? What are the investigation yang kita nak hantar?
chest X-ray
Hmm.
to look for mediastinal mass.
To look for mediastinal mass. Ya ke? Salah, I lupa lah. Untuk physical examination tadi kan, what else you have to look for? You have to look for complication kan? What complication yang you kena tengok? Kalau patient ada mediastinal mass, what do you expect to see?
Stridor.
Stridor, okay, good. So look for stridor kan? Lagi? Apa lagi? What else? Kalau you ada mediastinal mass, what structure akan compress? Besides your airway lah, besides your trachea, what else can be compressed? Your IVC kan, SVC kan. So kalau SVC you compress, you nampak apa? Apa dia Cuan?
Jugular vein
Huh?
extension.
Apa dia?
Oh, it's not.
Jugular vein distension. Okay, betul juga. Tapi dekat face you akan nampak apa? You akan nampak prominent vessel kan? You akan nampak prominent vessel dekat face. You akan nampak congested face. Lepas tu you kena buat sign apa? Apa yang you kena buat? What sign you have to elicit? Pemberton sign. Okay, remember Pemberton sign. Macam mana buat Pemberton sign? Pernah dengar Pemberton sign? Kalau patient ada mediastinal mass, okay, you kena ask them to lift up the hand, two hand. Macam orang kena tangkap no. And then you akan nampak engorgement of the vessel. So bila you angkat tangan, more you increase venous return through the SVC, kan? So you akan nampak engorgement. You akan nampak engorgement of the vein dekat your forehead, and then dia akan jadi flush. Okay, this is a sign of SVC obstruction. This is medical emergency. SVC obstruction, airway compression, these are medical emergency. Okay, you boleh buat chest X-ray to look for any intrathoracic lymphadenopathy. Okay, mediastinal mass. Lagi apa lagi? What other investigation yang you kena buat? Ada tak? Okay, you kena ambil LFT, RFT, basic lah, baseline before you start chemotherapy. And then before you start chemotherapy, you kena buat echo because some of this chemotherapy are cardiotoxic kan. So you kena buat echo, you kena buat eye assessment, hearing assessment because a lot of this cytotoxic drug are nephrotoxic and toxic to your eye, to your hearing. Okay, this is for preparation for ni lah chemotherapy. So management, these are the management, and then detail management I tak ajar lah, saya baru take je, you baca sendiri lah. Okay, ada soalan? Saya rasa satu case lah. Ni pun dah nampak lah. That's what PBL kan, usually one case je, and one case you need 1 week, 2 session. That's what we call PBL. And a lot of study done, those who did PBL as undergrad, okay, they are better in problem solving as a doctor. Tapi dia ada drawback lah. Dia adalah drawback, I tak mention lah what is the drawback of PBL. Because I really like PBL. Tapi PBL will lead to a better, more critical thinking and more creative with better problem solving ability of doctors. Tapi dia ada drawback yang very bad lah, yang tak bagus. So a good approach kan to PBL or a good case-based learning will help you to structure your thinking. Okay, this is how you have to think. When you read a case, this is how you have to think. First, you have to read through the case, determine the cues, and then from the cues, you have to be able to understand and explain the cues. That's only you are a good doctor. Faham tak? Faham kan? So this is how I'm going to run my session in future for case-based. We only got to do one session, one case. And I don't think we can do 2 lah. Maybe in future memang 1 case je lah. Any questions ke?
Doktor, kalau macam ni kan in English kan, so dia punya complaint pain and tenderness. Ada yang pain, ada yang tenderness. Tapi kalau bahasa Melayu, pain and tenderness, kita cakap sakit je kan. So ada.
Okay, tenderness is a sign. Okay, remember tenderness is a sign. It's not a symptoms. Faham tak?
Oh,
A
okay.
sign is something you elicit. You tekan sakit, then you call tenderness. Faham tak? Dia sama macam tachypnea and rapid breathing. Macam tu lah. Patient tak ada complain dengan tachypnea. You tak boleh kata patient complain of tachypnea. No, dia complain of rapid breathing. That is the symptoms. The sign is tachypnea.
So the pain is patient punya complaint lah, tapi tenderness ni bila kita elicit, kita touch tu. Okay.
Pain not necessarily relates to tenderness. Okay. Tenderness means something local lah. Tenderness means something local. Okay, apa lagi? Ini ada soalan?
Doctor, in this patient, dia tulis peticule in cheeks and chest. Important ke to know cheeks and chest or macam other part of the body?
Yes, it's important because cheek kan, cheek is where a lot of your capillary is. Okay, kalau you ada peticule somewhere else, for example peticule kat limbs, area yang commonly in trauma, then usually it's not that significant. Faham tak?
Faham.
Contoh you ada peticule kat kaki is quite common. Saat you lompat, sometimes you get peticule lah. So it's not that. Tapi peticule at cheek, at chest, this is usually a spontaneous peticule, and this is a sign of a more important lah, more important pathology lah. Okay. Lagi. This is a very good case. This is not that typical. Apparently most ALL in Malaysia datang dengan fever lah rather than bone pain. Tapi a lot of them, ramai juga datang dengan bone pain, tapi sometimes they don't complain lah. Biasanya is pain. Biasanya fever, hepatosplenomegaly, abdominal, ada lymphadenopathy. But remember, don't put ALL as your diagnosis because you are not certain this is ALL. Because ALL and ML usually can only be differentiated through bone marrow punya analysis. It's not, even FBP also cannot differentiate myeloid punya blast dengan lymphoid punya blast. Okay, ada soalan? Any questions? Okay, any opinion or anything want to say? It's okay dapat. Okay, ada soalan? Tak ada? Okay, tak ada, settle lah. Can we end? So we only managed to do one case. Hopefully this as introduction for our future class lah. And hopefully this can guide you on how to read a case. Learn from a case. Okay, remember, learn from a case. Rather than you learn from reading, I found learning from cases can help you to memorize better. Okay, can help your thinking more structured. Okay, I think that's all got. Okay, any last questions you want to dismiss? Anyone? Okay, kalau tak ada dah lah, kita tanggung dengan speaker for transfer to us. Okay, assalamualaikum warahmatullahi wabarakatuh.
Thank you, Doctor.
Thank you, Doctor.
Waalaikumsalam.
Thank you, Doctor.